Okay, so Dr. Wong is the head and consultant of the Occupational Medicine Service in Sengkang General Hospital. His practice covers workers' health and health issues at the workplace. He strives to make workplaces safer and healthier for all, and he's passionate about empowering workers to take charge of their health at work. So today he's going to speak to us about a rather interesting thing called return to work for the workers. Let's welcome Dr. Wong.
Thank you for the introduction. A very good afternoon to ladies and gentlemen. I must applaud SATA for the very noble work that you are doing with the migrant workers, as well as many of you in this room who work with migrant workers in the course of your work from various organizations. So today I am coming from the hospital side and to see at least from my perspective, what I think we can do more in terms of providing a more comprehensive healthcare for migrant workers in our midst. So I am going to talk about return to work as a therapeutic goal for migrant workers. Return to work is not new, I believe, to most of you. So, but I think in the migrant workers context today, there is still quite a lot of room for improvement. So. Without further ado, let me start my presentation. I specialize in occupational medicine. I must say that even today, this field remains a very mysterious field to many people, especially those who are not in healthcare. Even among healthcare, I have my colleagues from other specialties asking me, actually, what do you guys do? So traditionally, occupational medicine deals with occupational diseases. And as time goes, it has evolved to the management of injured workers, looking at fitness to work, looking at return to work issues, as well as being involved in workplace health promotion, being involved in workplace safety and health committees, looking at all these matters at the workplace, working with employers, working with HR, as well as being the advocate for the employees on the ground. So these are some of my some of the work that I do. Very simple outline of my talk. Let me start off with this introduction. There have been studies done in Singapore to show that workers who have sustained injury at work, many of them face difficulties returning to work. Up to 4 in 10 experience increased lethargy at work. Another 4 in 10 had difficulties in performing work at pre-injury standards. So the remaining 2 seem to be able to manage without any issues after their injuries. Among those who are injured, about 1 in 4 felt that certain work activities might lead to re-injury. Then there are also some who had the mentality that full recovery need to happen before they can return to work. But we all know that actually this is not true from other studies, because this has been disproved by many studies showing that gradual return to work can be a therapeutic goal, as well as to show that among those injured workers, if they have a lower self-perceived workability, this would lead to a longer duration of sickness absence, which will affect the success of them coming back to work after they have recovered from their injuries. This is a very familiar diagram to most of you in this room, I believe. The triangular relationship between work, health, and safety. So there is very strong evidence that most work is good for one's physical and mental health. That's why all of us are working in this room, I believe. And on the other hand, there is also evidence that job insecurity and unemployment have adverse effects on health, particularly mental health. Just now, we have a speaker talking about mental health of the migrant workers. A study done by Shiu found that 83.4% of workers who sustained work injuries took more than a month of sick leave, and with 1 in 4 of them becoming unemployed. So these are not this is not a small number. So talking about returning to work as a therapeutic goal, this study, actually it is more of a commentary done by my peers a few years ago, looking at this concept, how we can put this into practice. So I will elaborate a little bit more in the following slides. Now, sorry, there's a typo here. So this commentary, they talk about what are the precursors to a successful return to work. It consists of mainly three parts. Number one, we should correct the thinking that one needs to be 100% fit before returning to work. It doesn't have to be that way. It need not be so. Number two, avoid unhelpful terminologies and therapeutic approaches. This would be more applicable to clinicians when we are giving our advices to the workers in their recovery journey. And the last part, also the judicious prescription of sick leave and light duties. Likewise, we don't want to, in the past we have doctors giving very short MCs and then the workers get into trouble, and which also meant that the doctors also got into trouble, right? But on the other hand, we also want to avoid giving excessive sick leave and light duties such that, the workers are no longer motivated to get better and to see whether they can get back to work. So to elaborate on the first part, to avoid unhelpful terminologies and therapeutic approaches. So those, in general, people who receive a diagnosis, we all will develop certain belief or understanding about our condition. So, and those who hold negative illness perceptions are more likely to have slower recovery and future disability, independent of the initial objective severity of their condition. In recent years, there has been a shift to move from the biomedical model to the biopsychosocial model. So biomedical model is very straightforward. You have, there's something wrong with the body, and so what are the signs and symptoms that it manifests? Whereas when we talk about the biopsychosocial model, we also take into account the person's cultural, the background, his understanding about health, and his or her understanding about the signs and symptoms that he or she is experiencing. And this is to show what it means in this diagram. So looking at, so when we treat the individual, we don't just look at the health condition, we also take into considerations the bodily functions and structures, the activities that the person is doing, how they participate in, apart from work, in social activities, in their family commitments, and so forth. What are the environmental factors, for example, at the workplace and at their place of residence, as well as their personal factors. Then we also talk about avoiding unhelpful terminologies and therapeutic approaches. So I think whenever we see a worker in our clinic or in our setting, for those who are not clinicians, we all should try to help them to set an expectation that early return to work should be encouraged. In general, for most injuries, I'm not talking about those very severe injuries that the person becomes paralyzed. So those will definitely need a longer time of rehab, and returning to work may not be the most immediate concern for these people. So when we set the right expectation from the start, there is evidence to suggest that these will improve the likelihood of and to reduce the time of them being able to RTW. There have been some guidelines for it. This is one set by Royal College of Surgeons of England, as well as the Obs and Gynae, which have developed and published on their websites useful consensus-based guidelines on the usual timescales for resuming work after common procedures. So it can range from small things like incision or drainage of abscesses, removal of appendix, to bigger surgeries like I mean, what do you have for meals? Maybe hernia surgery, for example. You know, how much rest they should have before going back to work. So instead of going by what the worker or the patient tells you, this will be more objective. So yeah, then there's this thinking that the worker has to be 100% fit before going back to work, not just for the worker, but also the supervisor or employer. So we got to manage all stakeholders concurrently. As shown in this study, appropriate work can be therapeutic in recovery and should be viewed as an integral part of rehabilitation. To further elaborate, so for companies that are of a certain scale, or they have got number of different vocations, we talk about having a job bank where, you know, there are many roles in the companies, and the company should identify roles that, okay, by default, everyone is expected to do. And then whereas there are also some roles that are not as, for example, not as physically intense in nature, but you still need some people to engage in them. And once you have this list, whenever you have got workers who are injured and they need some downtime, or they need to be put on light duties, this is where they can still be productive while they are recovering from their injuries, and hopefully after a period of time, they can go back to where they were previously, assuming that recovery can, full recovery, I mean, almost full recovery can take place. But if not, then they can still continue with the company and be productive in their new role, or in the, with the necessary job modifications. Okay, if the doctor is unable to ascertain the work environment, you know, when you are seeing the patient in the clinic, and you are not sure whether with this, with the current limitations, whether he or she can do the work, it is useful to communicate with the employer or supervisor to find out more about the requirements on the ground, as well as to help them to understand what are the current functional limitations of your patient, and you know, the expected timeline as to whether he will get better and how long this is going to require, so that you know, people are on the same page right from the beginning. The last point on the precursors. So we talk about judicious prescription of sick leave and light duties. In Singapore, we have an MC-based system of MC, right? If you are not going to work, employer usually expects you to get an MC if you are sick. It's not very helpful in facilitating early return to work. In some jurisdictions like UK these days, now they instead of asking the employee to get a sick note, they replace it with a fit note, meaning to say, yeah, the person is actually fit to come back to work. Light duties, the usual format of MC, they don't help in communicating the patient's functional ability and limitations to employers. So whenever I have the opportunity, I'm talking to my medical friends, GPs usually, instead of just giving light duties, just writing light duties on the MC, it would be very helpful to the employer if you are more specific. We talk about excuse boots, right? So similarly in the workers' context, depending on the job requirements, if you know this worker had a shoulder injury or had an upper limb injury, is not able to carry heavy load, in the MC you state, you know, the person should not carry a load beyond how many kilograms, for example, beyond 5 kg, beyond 10 kg for the next 2 weeks, 4 weeks, and so forth. And then you request that this worker comes back to your clinic for a review 2 to 4 weeks down the road to see whether he has improved since the last visit. So that, you know, it helps to set the expectation of both the worker and the employer that this is something you expect it to improve with time. Yeah. So with appropriate workplace intervention of the advice of doctors, you know, or also known as a phased RTW, some of these workers have been able to return to work earlier or increase their likelihood of maintaining lasting RTW despite having residual symptoms. We talk about backache. Other speakers talk about backache just now, right? In fact, I believe half of you in this room, you are suffering some form of backache every now and then. It's just that you all soldier on, and you know, we need to put food on the table, right? We just have to keep going. So I talked about job bank earlier. Sometimes there might be a need to reskill or redeploy or make accommodations on the ground, so in order to help the worker to RTW. So there was actually a study done a few years ago to evaluate the RTW coordination program for injured workers in a public hospital in Singapore. And this study, they also included migrant workers as the participants. Let me highlight some of the findings in this study. Oops, sorry. Okay. Led by MOM, so they partner with 7 public hospitals to implement an RTW program. This was 7 years ago, right? Providing case management and coordination for injured workers to help them regain their work ability and long-term employability. Actually, all the efforts under RTW is covered under WICA, right? Allowing workers to file claims for work-related injuries without having to file civil suits. So what it means is that if the worker goes to see a doctor with regards to RTW consult, this is claimable under WICA, which means that end of the day, you know, the employer will be reimbursed for expenses spent under the RTW umbrella. So what typically, I mean, the setup is that this team of healthcare people running this RTW program, it usually comprises RTW coordinators, as well as admin staff to run this program. Let me see. So prior to this program, yeah, there was no standard clinical practice to facilitate the RTW of patients with work injuries. Any RTW issues were usually addressed by the treating physicians, the GPs, or the specialists or therapists on an ad hoc basis. So this RTW program makes it all much more structured in terms of how we manage injured workers and get them back to work. This is a workflow available on the MOM website. I believe most of you have seen this before. So if you want to find out more, there's a lot more information on the WSH Council website. So some findings on the migrant workers group. There is a higher likelihood of earlier RTW, and but then they also found out that some foreign workers RTW prematurely because of fear of repatriation, or they get their permits cancelled, especially if the employers place undue stress for injured workers to RTW earlier. And there's therefore a need for the RTW coordinators to work closely with employers to develop an RTW plan based on the patient's functional capacity and readiness to work, as well as to highlight the importance of injury prevention. So the coordinator needs to serve as an advocate for migrant workers to ensure they return to work when medically safe. So this is where I think some of us in occupational medicine, we can play that role as a coordinator. Today in all restructured hospitals, I believe there are people who are trained as RTW coordinators. These are usually occupational therapists. So again, to clarify, occupational medicine people, we are not occupational therapists. We deal with very different things. And so the occupational therapists, help people to rehab in terms of being able to go back to their jobs or being able to do their work activities. Oh, sorry, I think I jumped again. Okay. There's a bit of lag. Wait, can you go back one slide? Go back one slide. Go back one slide. Yeah. Okay. Migrant workers, in that study, there was also a higher dropout rate. So half of the dropouts had their work pass terminated and converted to special pass. Or some of them chose the common law to settle their claims. Right now, there is legislation to protect migrant workers who are terminated from work due to work injuries, hence the need for relevant legislation to safeguard their rights. The coordinators also need to educate injured workers on their rights under the WICA and keep them engaged. Coordinators play an important role in educating the employers on the benefits of retaining their workers, including maintaining productivity and reducing replacement worker costs. So the results, right, as mentioned, I jumped to the last sentence. So after adjusting for the above factors, the intervention group, this is the group that had RTW interventions, 2.2 times higher odds of return to work at 6 months. The lower workability score and a longer delay in initial RTW assessments were associated with a delayed RTW in the intervention group. So as far as possible, do this right from the beginning. Okay, moving on, I'm finishing my talk soon. This is still a voluntary program. I think it is important to raise the awareness, especially among employers, so that they can use this to help their injured employees to return to work safely, and also assist them in making an adjustment to the workplaces and jobs to facilitate the rehabilitation of your injured workers. So under WICA, all these expenses that concerns workplace visits to review the job requirements, coming up with the modifications are claimable under WICA. Then the RTW coordinators, as mentioned, are healthcare professionals. Usually they are occupational therapists, they help to coordinate between the treating doctor, the employee, as well as the employers, to communicate the care plans and to keep everyone updated on the patient's progress. So this is what what it typically covers, from case management, assessment of the employer's condition, fitness to work, worksite assessment, functional capacity evaluation if needed, personalized RTW plan, and training to prevent re-injury, and recommendation of modified work duties where necessary. So using some data from MOM, this is from 2023. Every day there are about 20 workers who are going to get injured at work. And so some of them, I believe, would actually benefit from a more structured RTW program, so that they can continue to remain in Singapore and work and be productive and support their families back home. As mentioned, all restructured hospitals in Singapore today have RTW program. It's a matter of people knowing them, employers knowing about this resource, and working with them to manage the injured workers. So I come here also with sort of a radical idea. I mean, since SATA CommHealth is the host, is that if just to explore whether there are opportunities for restructured hospitals or people like us, coming in to augment the PCPS services on the ground whenever you come across injured workers, whether some of them would benefit from a more structured return to work program, and at the same time cost I mean, we also have to keep it manageable, right? Because I also have to report to my CFO, my CEO, CMB, and you know they are also concerned about cost. You know, how does it you know, bring value to the hospital? So same thing here. I'm also mindful of you know, cost is also on the minds of every employers. While we want to make sure we take good care of our migrant workers, this whole thing has to be done in a sustainable manner, right? So that it can continue and scale up to bring more benefits to more people. So really, this is, I don't think, I mean today this concept, nobody has tried it, but if SATA is open and you know, maybe subsequently we can have more discussions on how to roll this out, or maybe have a pilot to see whether we can do enhance this for our migrant workers. So in conclusion, through our collective efforts, we can build a more work-focused healthcare system that benefits individual parties, our patients, and contributes to overall national resilience. In closing, I would like to pay homage to our overseas speaker, Dr. Arvind, because he comes from India, right? There's this quote, some of you might have heard it before, how talking about the society, a society is judged on how we treat our most vulnerable people. Does anyone know who said this? Very good. Yeah, so how we treat our vulnerable people, like injured workers, if we do a good job, I mean, that speaks a lot about how Singapore as a society takes care of, you know, people who are, you know, because injured migrant workers, can you imagine? I mean, they are alone here, their families are back home. You know, just now, there were some examples like, while they're injured, they also have family problems back home and they can't do anything. They also can't travel back because, you know, they have no money to do so. So, I think we can do more, especially for injured migrant workers, and perhaps this is something that is worth exploring. Yeah, and hopefully we can continue the conversation after this. Yeah, okay, thank you.
Thanks very much, Dr. Wong. So actually, a couple of months ago, we had one round of discussion about how we can maybe incorporate this RTW concept and clinic into what we are doing in our clinic. So maybe you probably can have a discussion further after the conference. Maybe Dr. Lee wants to be part of this as well, to provide your expertise and opinion. But any questions from anybody? Yes.
Hello. Yeah. Thanks, Dr. Wong, for that talk. I'm a family physician. I practice in a polyclinic. Very often, I do have patients who actually return, or rather they go back to their native country and receive medical treatment, and then they come back with a medical cert requiring us to endorse. Yeah. So in my practice, we actually do not practice endorsing of MCs, and sometimes we may not agree with the duration of MC that's given back in your own country. But my real question is, why should the employer of this, either domestic workers or migrant workers, not recognize the MCs that's given at their own country and require endorsement? I don't know whether this is the right platform to ask, but what's your approach for this? And perhaps Dr. Lee can also help to address this. Thanks.
I must say I don't have an answer. I think it's a matter of the company's policy, and it's a bit like SAF, right? They need the MCs to be endorsed, and perhaps this is something that they have borrowed from the SAF culture. So if there are patients coming to you with overseas MCs and medical reports that needs to be endorsed, I mean, my question would, perhaps I would pick up the phone and call the employer or call the supervisor to find out what are their concerns and to assess the patient who is in front of me, what is your current functional status and what are your job requirements? Is there any mismatch or do you need job modifications and so forth? Rather than just to endorse whatever has been given by the doctors in the home country. Yeah, I must say I don't have a perfect solution for that right now. Yeah.
I've got one more question.
Yeah, hi, Dr. Wong. Thanks for your talk. I'm from HOME, the organization helping migrant workers. So I think we're all on the same page that workers in general, and particularly migrant workers, are keen to return to work because they are here to support their families. They're not here to malinger or get out of work or anything like that. So you have also rightly pointed out that unfortunately they are more vulnerable to dropping out of return to work because due to circumstances beyond their own control, due to their employer's decisions, their work permit gets cancelled and they are no longer able to work legally, even if physically they're able to. And I would also like to point out that if they are on a special pass and not on work permit, they're actually not entitled to claim any MC wages if they are issued with light duty instead of MC. So that's one thing. The other thing I also wanted to clarify and see whether you had any observations or experiences on this was that when you pointed out that perhaps certain matters about the suitability of the person or suitability of the work environment for the patient's condition can be clarified with the employer. I just wanted to share that many a times we had injured patients, injured migrant workers. They share with us that sometimes when the employer is there in the consult room with the doctor, the patient feels like they're being very excluded. They feel like they cannot speak up. So even if the employer tells the doctor something that is not correct, inaccurate, say, yeah, I'll follow and I'll comply with the medical instructions about the work conditions. Actually, that's not what happens in reality, and the worker knows that it's not going to happen, but he feels very scared, so he feels like I cannot speak up when my employer is there. I cannot contradict my employer. So that is something you have seen, and I wonder if you have any observations on this or anything to address this point.
Thank you for the question. I agree with what you have said. Yeah, the employee is often excluded from the discussion, or they don't really have much say in the management. Again, right now I don't have an answer for that. I think what is missing right now is the inputs or the efforts by employers to being willing to do more for some of these injured workers. I believe there are enlightened employers who are already doing more than what is the minimum requirement, but I think there needs to be more. So everyone in this room, I think we just have to continue to do our part to advocate for migrant workers, to raise awareness among employers, perhaps also to push the regulators to do more in this space to hold the employers accountable in how they manage injured workers. What I think would be helpful if there are stronger legislations in terms of how the authorities hold employers accountable in how they manage injured workers. You give a very good example, like the worker is already injured, right? And so the work permit has already been cancelled. Now he's on a special pass. So there's no point in prescribing light duties or trying to encourage the person, can you go back and try to do some lighter duties? It doesn't make sense anymore. They are just waiting for the air ticket to be sent home. Yeah. So again, that is my observation. I don't have a solution for that today.
Sorry, just one more question.
Yes.
Yeah, sorry. Okay, from home also, and you also. I have questions about the policy of the RTW. Yeah, so earlier on you shared the percentage of workers losing their employments after the injury is 24%. But in our experience, we believe that it should be much higher. Having said that, we have several experience with doctors from the hospitals when we engage them together with the workers regarding of getting the MC. Yeah, so we realized that some of the doctor actually shared with us because they are given some guideline from the hospital about this RTW. So they are advised not to give to a standard MC. Yeah, even though they know that the worker is already on special pass, they are not no more employed. So for them is that they don't have this mindset into considering that, oh, that in this case, he's not allowed to go back to work. Should he be given MC instead? But the thing is that we do have a doctor who shared with us is, I'm sorry, my instruction is not to give any more extension or something like that. You see, so apparently it looks like there are some guideline policy by the hospital to the doctors, on something issues like this. Would you like to share about this?
I can only speak for Sengkang. To my knowledge, there isn't a written policy on this. In my conversation with orthopedics, with hand surgery, this has not popped up. And at least for Sengkang, the waiting time can be quite long. So they will give 3 months, 6 months TCU, and so in between they will cover with 3 months to 6 months hospitalization leave. I have not come across their patients given very short MCs in that sense. Yeah. So again, I think it's also a matter of raising awareness, even among clinicians. And since you are from home, if there's any opportunities to collaborate, to do further research, I mean, we are most happy to partner with you and to understand a bit more about this population.
Matthias.
Hi, I'm Matthias from St. Andrew Migrant Worker Medical Center. I don't have a lot of experience with occupational health, but as far as I know, according to the WSH Act, we refer patients, the doctor refers patients whom we think have occupational diseases under I think 30 over conditions in that list. But if there's an incident, for example, a toe fracture secondary to trauma at work, we do not refer patients to them. And the onus is on the employers to make an incident report. However, I think on the ground, and we can, it's probably widely known that employers probably, most of them do not do that, or they may not have the impetus to doing that because you invite scrutiny. So, firstly, is my understanding correct? And secondly, how can we address these issues of injuries, so-called minor injuries that don't get referred to the specialist clinics or emergency departments, but yet having the correct capturing of data of these injuries? Thank you.
So you're right. The notification of injuries has to be done by the employer. They are not reporting. I don't know. My impression is that today, by and large, most employers will report the injury. And will there be repercussions? I don't think so. Because every day there are 20. So in a year, you have got a few thousand, right? And nobody in MOM has the time to go after all these injuries to investigate unless they are spectacular. So I would say if there are people from MOM here, please, correct me. I believe more than 90% of the cases, it is just a statistics to them. Yeah, they don't go after the employer per se. So that's for notification. But for occupational diseases, yes, if you come across someone with occupational diseases, the doctor can notify straight away to MOM. There is no need to refer to OCMED for confirmation, but if you do that, we will also see them and and assess the patient accordingly.
Just a question from me. So I think we can appreciate from your presentation that having an RTW program is really beneficial for the workers and for the employers as well, because the workers can go back to work earlier. So I'm just wondering, in your experience, because I mean before this I didn't know about this concept. So do you think most workers who should be referred to your clinic are already being referred to a clinic, or are most workers still, they're still, you're not really reaching these patients who really need the service?
So from the OpMed side of the house, I don't think they are coming to us. And when we talk about injured workers, those with more substantial injuries that have to be admitted to undergo surgery, and usually they come under GS or they come under ortho, right? And once they are discharged, they go back into the community. In the hospital, these people are not given a OpMed TCU. They'll be given a GS or ortho TCU to go back and do wound dressing or to review, the cast and all that. So that could be one area to start looking into. Number two is when these workers, they go back, do they come to, for example, PCPS to have follow-up before the MC ends and they go back to work, or do they just go back to work after their follow-up with the specialist? So some of these things, and then it's also a question of whether it would be feasible to have a mechanism whereby once you have an injured worker, it triggers a chain of responses. So yeah, for example, the employer is notified that this worker is injured, has been hospitalized. Then there's also a notification that goes to, for example, PCPS to say that this worker has been hospitalized, has undergone surgery. When is he going to be discharged? How long is the MC given? And then so during this period, would there be, is it feasible to have a visit to the PCPS to see how the worker is doing and so forth? So things like this. Because this RTW concept has to kick in early and not wait until the company decides to cancel the work permit and then, we end up in a situation whereby, it becomes a lost cause. There's no benefit there's no incentive for the employee to remain with the company.
Yeah, so I think exactly right. So I think we need to catch these patients early enough for them to benefit from the program, right? So sorry, for the RTW clinics, do you guys accept referrals from the GPs as well?
Of course.
Okay. Any other questions for Dr. Wong? If not, thanks very much for the presentation. Thank you.